Thank you very much indeed, and it's a pleasure to be with you this evening to talk with you about demoralisation, a state which some people might think of as an adjustment disorder. Others might think of it as a challenge in coping, but we certainly recognise that it's very common. To define it, we would say it's a mental state where a person's morale is lowered and where they have a sense of poor coping, in which they can feel trapped in a predicament, which may be a medical illness, it may be a setting of palliative care, it may be efforts to treat a particular illness that's proving to be challenging or difficult for the person. And as they feel trapped, they may start to feel some helplessness and hopelessness. And as that develops, often some loss of meaning, purpose or value in life then emerges. So in differentiating demoralisation from depression, it's important to recognise that depression's a pervasive state where interest and pleasure is lost. In Munch's image there, it's a pretty settled and continuing state of mind. There's no enjoyment in the here and now. Whereas for demoralisation, the loss is about hope for the future, where the person may not see a point to their future, but they can have fun in the here and now, they can laugh, they can joke, and enjoy the present. So they're not pervasively sad like the depressed person is. In this particular talk, I want to review this concept of demoralisation and take a quick look at the background literature. I want to touch on measurement and consider how it operates at a level of the brain. Is there a hope centre in the brain? I want to ask how this construct fits into the diagnostic system, and then review with you how we would go about treating the person who's demoralised. Before finishing, I want to cover a screening approach to recognise psychoexistential symptoms, particularly in the palliative care setting. And I'll finish by referring to how contagious demoralisation is. I'm acknowledging many collaborators who have worked both here and in other countries in recent years on this topic. So here's a painting by Bramley from the Tate Gallery, in which you see the woman looking in a state of despair there, and it's known as the hopeless dawn. Morale occurs on a continuum, and people may start off losing some confidence and feeling disheartened. Then if their morale drops further, as seen in a picture of people who become unemployed, the person starts to lose hope and purpose. They doubt what can happen, and despondency is much more pronounced. And then in a most severe form, hope and meaning become lost, with despair and what we're terming demoralisation becoming truly present. So I'm using the word demoralisation to represent the severe end of this spectrum, but we recognise the dimensional nature of the overall construct. It's just pathological when it's severe. It's an old concept that we've reactivated in recent years. Viktor Frankl saw it in the concentration camps, and he said that suffering itself does not destroy man, rather suffering without meaning. George Engel in Rochester in the United States described the giving up, given up syndrome, a state of demoralisation, where Gruenberg, in looking at those in asylums, chronically mentally ill, saw how they had a social breakdown from others in their world. Jerome Frank wrote about demoralisation from the perspective of psychotherapy, and he argued that the most fundamental step in any counselling was in fact to restore hope and morale in the person. Seligman was responsible for a wonderful body of work about learned helplessness, which has much similarity. For me, I was listening in 1996 to Susan Folkman giving a talk about coping at the annual psycho-oncology conference in Hamburg that year. And of course, she'd done her PhD with Lazarus and had described the major approach to coping, describing it as either being emotion-based or problem-based in the 1980s. In the 1990s, she was studying the carers of people who were dying from AIDS. And she became intrigued by how much joy and happiness was present in their lives. And she came to realize that it was the meaning that they derived from their caregiving role, which contributed joy and happiness, their positive affects, and even resilience. And so it dawned on her that meaning-based coping had been completely omitted from their original coping model. And she then has since introduced it. And it's fair to say that meaning has been broadly neglected by psychiatry, yet it's a concept that's very central to existential distress and met quite often in cancer care and in palliative care. So around the year 2000, when I was working at Peter MacCallum, we developed the demoralisation scale, validated it and published it in 2004 there with 5 subscales that you can see named in the blue as dimensions of that measure. And over the next decade, that demoralisation scale was translated into more than 12 languages, taken up in many different countries of the world, and that proved to be evidence of the recognition of it and of its contribution to clinical concerns. Its real importance clinically is in the recognition that people who become demoralised may go on to develop a desire to die, and that then becomes a very serious state of affairs. So in about 2014, Sophie Robinson came along to me to do her doctorate, and she started with a systematic review of demoralisation, looking at the research over the preceding 10 years. And she found in her systematic review that she could identify about 25 studies in palliative care, which encompassed more than 4,500 patients. And she identified that the prevalence of a demoralised state was between 13 and 18% across these studies. If we round that off to 15%, we would say that it's a very prevalent condition, and we need, therefore, to recognise it and know about it. The predictors of demoralisation, those that have a positive association and seem to contribute, include states of aloneness, where people may be single, separated, divorced, or widowed. Reduced social support is clearly a predictor. It's more common, we see in studies in women than in men, which is similar to depression and may have a biological basis for it. Physical symptom burden seems very much to bring it on. So in palliative care, when we're not treating physical symptoms well, people who are suffering pain or nausea or other disabling symptoms become demoralised. And in like manner, if people have a mental symptom burden, if they're sad, depressed, anxious, distressed in some way, then they may become demoralised as well. The things that are protective or are negative associations include being married or well supported, being employed, having a spiritual or religious dimension to one's makeup. Exercise is helpful, as is good quality of life. And some people have a very strong sense of purpose in their life with what we might call a generalized hope in their background. And this sustains their hope even in difficult circumstances. If we take a model then that helps to explain how you can move from a state of being distressed to a state of desiring to die, becoming what psychiatry might think of as being suicidal, we've got a range of mediators that influence that progression and a range of moderators. So we see over here poor symptom control and functional disability are moderators of becoming more distressed. Social support, good support, protects against it, as does a resilient personality and somebody with strong religious beliefs. But these moderators don't directly create a desire to die. There has to be some mediating pathway that occurs. And the pathways include losing meaning in life, having a reduced sense of self-worth, losing hope, and in some cultures, particularly in the Japanese and Koreans, the development of shame may also be a mediator. To offer you some research evidence that those pathways do in fact exist in the real world, here's a study from Taiwan which looks at the mediation between distress and suicidal thought, and it finds that depression is very weakly a mediator, but demoralization is significantly strong and powerful. And here in this table, we see that demoralization has a value of 2.84, where depression isn't even making 1. So that the loss of meaning is a very important mediator of suicidal thought. And Sophie Robinson did this for quality of life. And if you look at these beta values, meaning and purpose 0.3 and perceived control or loss of control over life, loss of self-worth, significant. Depressive symptoms, a much smaller score. And finally, Sigrid Veiling, working in Hamburg, has contributed a study here where she looks at a large cohort of cancer patients who become demoralized and compares them with patients who are depressed. And in this right-hand column, she controls for mood and anxiety disorders in working out what the risk ratio is for a person becoming suicidal. And you see here in blue that demoralization has a 3 times risk ratio, whereas depressive disorders are not significant again. So the importance of demoralization ultimately is that it's a strong pathway for people developing a desire to die. Demoralization has also been studied in other settings, and here we see that amongst substance-dependent people, opioid-dependent, in this case in the Netherlands, people who are heroin dependent had levels twice as high as you find in cancer. David Clark's work with motor neurone disease, much stronger demoralization amongst patients with motor neurone disease than patients with cancer. Parkinson's disease is a neurological state that exemplifies a tendency for people to be demoralized. And Irene Bavetsky studied postnatal women, and she saw that separate to those who develop postnatal depression, there are a group of mothers approaching 10% there, 8%, who had a clinical demoralization state present as they struggled to cope with the demands of their baby. Demoralization scores in the medically ill can vary, and if you take a score of greater than 30 in this Italian study as indicative of a clinical level of demoralization, then we see patients with neurological, cardiac, respiratory, and non-specific disorders having high states of demoralization, compared, for example, somebody with an infectious disease such as pneumonia, which might be thought of as being treatable and not so likely to make people demoralized. In this non-specific group are people with chronic pain syndromes and also people who have drug and alcohol problems. So certain medical disorders have a greater tendency to bring on demoralization than others. Here's an interesting study from the Netherlands which looked at a group of women who'd had their ovaries removed because they were BRCA positive, the BRCA genes predisposing people to breast or ovarian cancer. And so having had the protection of an ovarectomy, you might think that they would be in good emotional states. They were considered a healthy cohort and generally thought to have low anxiety, but when studied, some 16% were found to be demoralized. So even when people have had some protection, but they carry a cancer-prone gene, we can see in this setting, some existential strain starting to emerge and being responsible for that demoralisation. Now, of our early scale that we developed in about the year 2000, we were aware of a few psychometric weaknesses, and we went about therefore refining it and revalidating it. And we came to an improved scale with just 2 subscales, a meaning and purpose subscale and a coping ability subscale. And this had very good validity, reliability, and on this slide, validity with measures of symptom burden, of hope, of depression, and of a desire for hastened death, SAHD on the left there. So these are all significant and point to good convergent validity. We also had evidence for discriminant validity in that when people had a high score on this measure, they had a poorer functional status on Karnofsky's, and they had high symptom burdens. Comorbidity with depression was not found to be statistically significant at moderate levels of demoralisation. So this is what the modern today version of the demoralisation scale looks like. A list of 16 items. You can cast your eye down those items. They're framed in a negative direction to see that when people endorse some positive scores here, 5 or 6 of these being endorsed positive are likely to give people a clinical level of demoralisation, a score of 10 or more, certainly pointing in that direction. And our Italian friends have then reduced the number of items in what looks like a very busy scale. But here in blue at the top, we had the original 36 items we started with. And in 2004, we published our first version with 24 items. We subsequently refined that to a 16-item version here in Australia. But in Italy, they came up with a 13-item version. And just to see if they could come to a very small screening tool, they brought it down to 6 items that you can see there in the green. And those 6 items also had very good psychometrics when one uses item response theory as a way of assessing the validity. One way of comparing them is to look here between the 24-item measure, the 13-item measure, and the 6-item measure. And at the bottom, if you look at sensitivity and specificity, these are ways of determining how valid the measure is as a screening tool. And you see here that you're getting very comparable figures in the mid-70s there for this as a screening tool. Now I want to introduce you to a new statistical approach. It might seem a bit technical, but let me walk you through it and see if I can help you to make sense of it. This is termed network analysis, and it's done when one wants to look at the dimensional nature of a state of mind. And here we're looking at a cohort of nearly 450 Italian patients who've been medically ill. And you're seeing there what's called an exploratory graph analysis, where any one symptom, like helplessness here, if I put the cursor on helplessness, in the blue, that symptom is represented by what's called a node. And then the symptoms in pale blue form a community. The symptoms in pale green form a community. And the statistical program uses a repetitive 1,000, 2,000, 10,000 iterations to ensure that these communities remain stable. But in particular then, it looks at the green lines, what are called edge weights, the green lines representing the strength of association between any symptom. And so we have strong green lines when there's a strong connection and very weak, faint lines when there's a weak connection between symptoms. Now here, we've put the symptoms of depression in red because they belong in a community together and they relate very closely to each other in that red community. Whereas the symptoms of demoralisation are found in these other 3 communities, quite separate to depression. And I think in a subsequent slide, we just make that a little bigger It's rotated slightly, but it's the same image. And I wanted you to see at the bottom here in purple how symptoms that we term entrapment, feeling entrapped, stuck, really locked in, is very close and heavily related to distress, but also strongly related through this green line here to a state of discouragement. I also wanted you to look and see how death ideation over here in the pale green on the right, where the cursor is, that death ideation is strongly linked to a lack of purpose in life, sense of hopelessness, pointlessness, loss of value. And so you see the strongly demoralized symptoms feeding into that death anxiety, death thoughts, desire to die in a very strong way. So this network analysis really shows us how, on a probability of a symptom belonging to a community, that the depressive symptoms in red are completely separated from the demoralization symptoms, where low morale and a sense of frustration with being isolated and losing purpose in life, they really become quite discrete and separate from depression. Network analysis also enables you to look at whether a symptom is particularly strong within a community. How central or determining of that community is it? And those that are most strong come out as having the strongest centrality. And here we tell you where the cursor is, that pointlessness, low morale, hopelessness, and entrapment are the four most determinative or central symptoms to the construct of demoralization. And the importance of identifying central symptoms is that these should be therapeutic targets. If one's going to help a demoralized patient, these are the very symptoms that we should be trying to work on to turn around and improve the morale of that person. Pointlessness, discouragement, hopelessness, and feeling trapped. Just to show that that particular Italian set of results is not a unique or, just a fluke occurrence, here's a different cohort analysed in a comparable way, but in this instance they're over 1,500 cancer patients, data we're just preparing for publication. And here again, we see that the depressive symptoms completely separate from the demoralized symptoms. In this analysis, the depressive symptoms have been placed in purple and the demoralized symptoms in red for the very strong ones. And again, you see that thoughts of death strongly associated with the development of pointlessness, hopelessness, and helplessness as the symptoms that cluster around those death thoughts. You see again that feeling trapped is strongly linked to the development of distress and of isolation. So this validates the findings of the first analysis in a really very, very similar pattern, even though the subjects were completely different. Finally, in this little bit of technical, analytical component to the talk, I just want to point out that there's a reciprocal relationship between demoralization and depressed. You can start off being demoralized, and if you stay demoralized, you may develop depression. And we say that demoralization as poor coping is in that sense a harbinger of depression. But in like manner down the bottom, if you're depressed and you stay depressed, then you can become demoralized, where demoralization represents further poor coping. And this statistical portrayal of this shows how each state can cause the reciprocal state in a person. Now let me turn to a bit of anatomy and physiology and talk about the hope center in the human brain. We recalled the history of this and said it's really an old state. Engel called it the giving up syndrome. Others have called it give-up-itis or mental defeat. And John Leach, in writing about this, paid particular attention to prisoners of war and how when they were trapped in camps, they lost their morale, felt trapped, and life lost its point and meaning. Viktor Frankl, in fact, predicted that certain people he observed in the concentration camp would die because he saw them in such a hopeless state. And we've come to appreciate it. This is a dopamine-mediated frontal part of the brain, the forehead of the brain, linking in with subcortical circuits. So the emotional life of the brain operates through what's called the corticolimbic system, where the front part of the brain here relates to this cortex that curves around the ventricular or fluid-filled spaces of the brain. And we come into deep parts of the brain where the amygdala is where emotional distress and learning is particularly found. And the hippocampus in blue here is the center of memory. But it's the nucleus accumbens at the very end of what's known as the cingulate cortex, the nucleus accumbens just where my cursor is now, which is the hope center. And when we look at depression, we tend to talk about the serotonergic medications, the SSRIs, for treatment of depression. And the mood functions are very much shown there with serotonin as the neurotransmitter in those pathways. But alternatively, in the blue are dopamine pathways between this front part of the brain coming in to the nucleus accumbens and finding that as the central part of our hope circuit. So when we think of this hope system, we start off with this nucleus accumbens region of the brain, and motivational salience or desire, wanting, hoping for something is found to be located in the nucleus of this particular part of the brain. Then it talks to the frontal cortex to place goals and values on those wishes or hopes that it has. Memory is invoked to consolidate those desires, and then ultimately motor programs are set up to bring about the reward that is hoped for. And it's the core region of the nucleus accumbens that sets up those motor programs to go after what is hoped for. So we have a hope system in the brain, and we can see dysfunction in that system leading to a loss of morale, or what we're calling a state of demoralisation. If we were to put this in the language of the DSM, the American Classification System for Psychiatric Disorders, we might argue that it should be a persisting mental state over 2 or more weeks, where lowered morale and distress results, where there's difficulty in coping and in meeting the expectation of oneself or others, and that you might get 3 or more symptoms being pertinent here. The development of pointlessness, hopelessness, and feeling trapped, stuck, or losing control over one's life can be pertinent. You can have a drop in self-esteem, a sense of failure, and then a desire for hastened death could develop, with suicidal thoughts becoming consolidated into plans. DSM would require that this low morale and poor coping causes significant distress or impairment in social functioning, occupational functioning, or bodily functioning in some manner. How we socialize, how we mix, or whether we withdraw from other people. So the question comes, how do we fit this notion of demoralisation, which I argue makes such good sense, into a DSM or an ICD diagnostic system? Here we have to make use of what's called a specifier, where specifiers delimitate certain symptoms or phenomena, and they give specific subgroupings to a disorder. And those subgroupings may have an impact on treatment and may guide the choice of treatments that are used. So the DSM has tended to use specifiers, particularly with adjustment disorder, which is the DSM label for poor coping. And they typically would use specifiers such as adjustment disorder with depressed mood, with anxious mood, or with behavioral conduct disorder. Major depression can have specifiers such as melancholia or with psychotic features. We wanted to test whether demoralisation made sense to clinicians, and so we created 6 clinical vignettes and circulated these to some 320 members of these different societies. And we saw in the responses that we had, first of all, responses coming from psychiatrists, psychologists, social workers, physicians, nurses, and an overall count. We had a vignette for grief, and we saw that the vast majority, in the high 90s of people, correctly recognised that vignette for true grief. We had a vignette for adjustment disorder with anxiety, and there you see a very middling to lowish kind of level of ratings where people weren't very good at picking this diagnosis when the vignette clearly pointed to that. And thirdly, we had a vignette where the person expressed low morale with demoralisation, as I've been explaining it. And here you see much better scores. They're not quite in the 90s like the grief scores were, but they're in the 70s and 80s, and they really show us that clinicians are much better at recognising demoralisation than they are in recognising an adjustment disorder with anxiety. And when we look at what this means in terms of their usefulness, their utility or usefulness to clinicians, we tested clinicians' view of how much did this help in understanding the patient? How much did it help in choosing a treatment? And was it of assistance also in communicating with other care providers about continued care needs? And we see in the blue that the mean scores recorded by these clinicians are much more in favour of adjustment disorder with demoralisation than they are for anxiety or even for grief. So clinicians perceive utility in understanding this. Now, I just want to take you to a different analysis, to this large cohort of cancer patients, over 1,500. And now we're going to have a look at what's called a latent class analysis, which uses a statistical likelihood method, a Bayesian technique so-called, of how likely is a particular symptom to belong into a particular class or group of symptoms, so that you might say they form a cluster or the most probable class. Well, that might seem a bit hard, but let me make it more simple by saying that you get 4 classes. And the first class, which has more than half of the patients falling into that class, is deemed normal, because there's a very low probability of any of these symptoms on the left being found in that class. And the second class has 1/5 of the patients in that group, and it has one group of symptoms that are called somatic, with about an 81.6% probability here that somatic symptoms will be endorsed by this group of patients, who also have reduced functioning and they have more than 3 physical symptoms troubling them. The third class, representing about 10% of those 1,500 cancer patients, is the most severe in terms of psychopathology. This is the class, the 10% that carry psychiatric disorders, and in particular, the only group that have depressive symptoms, such as loss of interest or feeling sad, and anxious symptoms, such as concentration being poor, feeling nervous, worrying a lot. But we also noticed that these people with anxiety and depression have quite a number of these symptoms in the black, which have a probability of suggesting they're demoralised. So these patients appear to be both depressed, anxious, and demoralised. They've really got it all. Whereas the final class, class 4, with another 13%, has in fact high probabilities of endorsement of the demoralised symptoms shown here in the red. But they don't endorse depressive symptoms, they don't endorse anxious symptoms, although they're getting to be physically sick with poor functioning and prominent symptoms. And this is a group who are coping poorly without depression or anxiety. We might, in DSM terms, call them a group with adjustment disorder and demoralisation. And to show you these four classes with different measures, a measure of functional impairment, highest in the most severe class, as is a measure of anxiety and a measure of depression. These people in this severe class, nearly half of them become suicidal, and they certainly have no pleasure. They're anhedonic, and they have quite a lot of demoralisation, with a score of 45 on the demoralisation scale. But when we look at class 4, which is the adjustment disorder with demoralisation, although they're functionally impaired, they don't have clinically significant scores for anxiety or depression. They tend to have more advanced cancer in this group, and yet 1/3 of them also become suicidal. So you could say that they're just as likely really to become suicidal as those with the very severe depression and anxiety. So this is a group who are demoralized, but not depressed, not anxious. We need to recognize them and treat them clinically. In the DSM, adjustment disorder, the label that's used for poor coping, has been a sub-threshold disorder in a hierarchical sense. By that we mean that if you're going to make a diagnosis of adjustment disorder, you've first of all got to exclude a major depressive episode, you've got to exclude generalized anxiety disorder, you've got to exclude post-traumatic stress disorder. Not liking the DSM, the ICD panel in Europe has tried to make adjustment a threshold disorder, arguing that it should have its own unique set of phenomena, symptoms and signs that make it recognizable as potentially a suicidal state, and that it should be diagnosed separately to and distinctly from depression or anxiety. And the argument for this is built up in a number of studies. Here's one example, a Danish study, which looks at those who have completed suicide and does a psychological postmortem on them to see if some of them have had an adjustment disorder in contrast to, say, a clinical depression. And they find, in fact, that 7.6% have an adjustment disorder, and that there's 12 times the rate of suicide for those with an adjustment disorder than those who didn't have an adjustment disorder. And here's another study coming out of Ireland in this case, which compares people presenting to an emergency department with suicidal behavior. They may have taken an overdose, they may have self-harmed in some way. And we see that of the group amongst them who are depressed, 1/4 are suicidal, and similarly 1/5 are suicidal amongst those with an adjustment disorder. In broad terms, these are not statistically different. And we see that people with adjustment disorder do have suicidal attempts, and therefore it's a very serious condition to consider. If you say to a clinician as a psychiatrist, particularly if I give an opinion back to an oncologist, this patient's got an adjustment disorder, they tend to look at you very blankly. They don't know what you mean because it's such an obtuse label. If, on the other hand, you say this patient seems to be demoralized, I find that oncologists understand that language. They make sense of it, they recognize it, and it helps them to know what to do with their patients. So I'm arguing to you tonight that demoralization is an important specifier of mental disorder, that it could be used as a specifier in DSM. And the phenomena that represent demoralization match very nicely the phenomena that ICD is introducing to give us a deeper understanding of what an adjustment disorder is like. So we could call an adjustment disorder a state of demoralization. And we see that particularly with the moderate symptom cluster in that latent class analysis that we did. Now I want to go on then in this 5th section, just talk for a moment about the treatment of it. The important thing here is that the treatment of depression tends to need antidepressant medication. The treatment of demoralization need not. So one body of work that's looked at this is Breitbart's work in New York, where he's developed Frankel's logotherapy into meaning-centered groups. Group therapy, where the group seeks out meaning. And this is a model which is fairly educational, and the members of the group are taught, often cancer groups, they're taught to identify sources of meaning in their life. They're taught to look at the narrative of their life to see how they've derived meaning from their career, from their relationships, from their hobbies, from things that have brought pleasure into their life. Creativity is often involved, and humor and art, the beauty of nature, these things all deliver meaning to people. The groups also acknowledge the finiteness of life and help people to hold out hope, to live their life out fully, to say goodbye well if they have an advanced disease. And Breitbart studies have shown benefits in this meaning-centered work. In Toronto, in Canada, Gary Roden's group at the Princess Margaret Cancer Hospital Cancer Centre have used a different model called calm therapy, where the L and the M of calm are about living meaningfully. And this is a model that combines palliative care symptom management and improved communication with healthcare providers with a search for meaning and purpose as it seeks helping people to find that added meaning in their life. At 6 months, they showed a small effect in reducing depression. But what is of interest to me is that for people who had high death anxiety at baseline, they had here a Cohen's D of 0.5, a moderate effect size. So that's a good result from a psychotherapy study in ameliorating demoralisation amongst their patients. And in Melbourne, Carrie Lethborg, a social worker at St. Vincent's, has really focused her postdoctoral work on what she calls meaning and purpose, or map therapy, where you create a roadmap of how you're going to have this meaning in your life and what purpose you're going to lay down as new goals, new choices that you make to live life out fully and to make it of value and beautiful for you. And in pilot work, here we've been able to look at the outcomes of a pilot study giving meaning and purpose therapy to cancer patients. And for those who understand effect sizes, on the right-hand side, we're getting quite promising effect sizes for people becoming aware of new possibilities and appreciating life and their personal strength, their resilience on the post-traumatic growth inventory, while also we see good effects for increased goal seeking and choices. And so that's a study that we're putting into practice in a formal clinical trial to show its benefit. I wanted to touch on one other program that we're rolling out now, which is being funded by the Commonwealth, and it's being titled Screening for Psychoexistential Symptoms, assessing for the presence of these in palliative care patients. Those who understand palliative care well will know that back in 1991, Eduardo Pereira created the Edmonton Symptom Assessment Scale, which assesses for the level of pain or nausea or fatigue that a person might have. These were his original items that were assessed. And in Australia today, palliative care services collaborate with the Peacock group at the University of Wollongong, and they record scores out of 10 for these symptoms that people have: a pain score, a score for breathlessness, for nausea. But you notice there's no psychosocial score, there's no score for coping or for the mental aspect of it in how palliative care in Australia records and measures this as a quality improvement measure. So we argued as a research group to the Commonwealth Department that this led to a neglect of psychoexistential symptoms that created a vulnerable population, which led to people spending more time in hospital and increasing the cost of care. It increased complexity and suffering, and Tears that were present might be normalized as grief, but certainly staff lacked confidence in how to respond and know what to do with these people. So we proposed a program which we've been funded to roll out over the next 3 years, where we introduce a screening tool to palliative care services to help them to screen for psychoexistential symptoms, and to then roll out workshops that train people and upskill nurses and physicians and allied health workers to be able to discuss these symptoms with the patients they're caring for. So this is what our symptom assessment scale looks like for psychoexistential symptoms. And whilst you can see that anxiety and depression are sitting towards the bottom of the list, I hope by now you'll have recognized that the top half of the list is made up of symptoms that we find in people who become demoralized. And we're going to train services to become better by getting a score out of 10 on any particular day, to recognize how discouraged, trapped, hopeless, pointless, feeling out of control, feeling that they've lost roles in life, even developing a wish to die. So we're going to employ this, and we're going to, in workshops, teach people how to have a conversation about a symptom. After all, if somebody gives you a pain score and they say their pain is a 7 out of 10, then you don't just stop there and write that down and walk on. You ask them about that pain. Where is it? How's the medication helping it? What's made it worse? What's made it better? What changes it? And there's a whole process that clinicians work through when they work with a pain score. In a similar way, if somebody says they're discouraged, we want the clinician to name that emotional state. Oh, you're rating your low morale, your discouragement as a 7 out of 10. Then we want you to empathize. That must be so hard for you, such a struggle. Let me understand a little more what's contributing to this low morale. What do you think causes it? Has it dipped in the past? When did it begin for you? What really brought about that lowering of your morale? Oh, it was when you were told something more about your prognosis, some change in the chance of you keeping this illness under control. Have there been other factors that have lowered your morale? But I wonder if there's a resilient side to you. Is there a part of you that represents your strengths and that can help you to restore that morale, to fight back and to do better? Well, overall, we want to seek permission once we've got an understanding of that symptom and seek permission to do something about it. Sometimes just talking about it will be helpful, but you can ask the person, should we be helping you more with your morale? What if we asked our psychologist or our social worker to spend more time with you, to talk with you, and to in fact see if we can help to improve this for you? So you'd effect a referral with permission and document a plan of care. So this is the strategy that we'll take out in our workshops to teach people how to deal with these symptoms. I'm moving now to my final section to give you a few moments for questions, but I want to finish by just talking about how contagious the demoralized state is. So if you have patients who become demoralized, you'll often find that their family members, their caregivers, will become demoralized with them. And it's also possible for teams of clinicians, nurses and physicians to be demoralized as well. So sometimes in medicine, we talk about burnout. And I want you to think about, how does a demoralized doctor or a nurse differ from somebody who's burnt out? And sometimes in palliative care, we might see somebody who has quite a lot of body decay. Imagine a person with a large wound that's become ugly and revolting to look at. And they may perceive that this patient has lost some dignity in the presence of that smelly wound. In psychiatry, we teach about countertransference disgust, just as people talk about countertransference hate. And so you have to tune in to how you're feeling as a clinician. And if you think that a person is looking pretty undignified, disgusting, there's something quite revolting about this bed sore this wound that their body has, then you need to be thinking about how this is impacting on your care provision. And are you viewing them as unworthy of life? Are you giving up on them? Or are you thinking of constructive ways to treat and care for them? So demoralisation in teams and in clinicians is important. And you hear about it best of all in the coffee room, where the nurses come in and they debrief with one another, and they say things like, oh, isn't that smell in such and such a patient's room terrible today? Oh, it gets you down, doesn't it? So demoralisation is real in medical teams as well. In families, when symptom control is poor, where the palliative care team is struggling to manage the symptom as optimally as they might, then families sense helplessness, sometimes at the plight of their relative. They look on and perceive a loss of dignity. They have a negative perception of the person's future, and they may become quite demoralised. Demoralisation is more intense in families that are dysfunctional. So if there's poor communication, poor teamwork, if there's conflict and disagreement in the family, then you're very likely to find demoralisation amongst family members. We can treat demoralised families with family therapy, family meetings, and in formal studies, we've taken these family meetings from the palliative care phase and continued them into bereavement as a model of supporting dysfunctional families. And in our early work in Melbourne, working with 81 families, we in fact showed that at 13 months of bereavement, we could reduce the amount of bereavement distress, depression, and improve social adjustment. And we wrote about that in that family-focused grief therapy book that we published, in fact, in 2002. And in New York, when I worked there for a decade at the Sloan Kettering Cancer Center in their Department of Psychiatry, we did a study with 170 families, teaching many more therapists this time to deliver the therapy so that it moved from an efficacy to what's called an effectiveness randomized controlled trials. And this time we showed that we could prevent prolonged grief disorder in bereavement, with those in the therapy having just 3% of the families with prolonged grief being present. Whereas for those in the usual care arm receiving the very best of palliative care, but not these family meetings, 15% of them develop prolonged grief disorder. So here we've proven that if we meet and work with these families, we can in fact ameliorate their distress and protect them from complicated grief. I do like to comment that if a person is demoralised, it can have an impact on their capacity to consent to treatments or to the withdrawal of treatments. After all, if you appreciate that you don't have much of a future, that you view your future in demoralised or depressed language and view it through rather black or dark glasses, then that disordered relationship to your future could impact on decisions that you make in the here and now. And if you've decided that your life is pointless and meaningless, and you want to make a choice for physician-assisted suicide, that mightn't be the choice you'd make if you weren't demoralised. And so it becomes very important that we recognise and treat demoralisation. So to conclude, demoralisation is common. We see it in adolescents, we see it in drug and alcohol patients, we see it in women postnatally, we see it in the medically ill. And we certainly see it in palliative care, where we've found that it has a 15% prevalence rate. It's a form of poor coping or an adjustment disorder with demoralisation. And we do know how to treat it, and we do know how to screen for it and recognise its presence. There's much we can do to help these people. And so I commend it to you as a worthy clinical state, worthy of your recognition, worthy of your treatment. Thank you for listening to me, and I'm very happy to respond to any questions that you might like to ask.